in this second to last section of this chapter, we're going to talk about the cerebellum and disorders of the cerebellum. We will also revisit the cerebellum in chapter 15 when we talk about the brainstem, because it's very closely related to functions of the brainstem. So the cerebellum has so many neurons, massive amounts of sensory information come into the cerebellum, and cerebellar output is vital for normal movement. So you could have severe damage to the cerebellum that does not interfere with sensory perception or with muscle strength, but you don't have coordination of your movement and you don't have postural control. So the cerebellum is really important to movement. So you can have perfect sensory perception and perfect muscle strength, but if you don't have coordination of that movement, you're in trouble. So the cerebellum, it coordinates movement and postural control by comparing actual motor output with the intended movement and then adjusting the movement as necessary. So in chapter 6, when we were talking about the unconscious relay tracts, they all end in the cerebellum. So the all that information coming in from the somatosensory system is used by the cerebellum to compare the actual motor output with the intended movement and adjust the movement. So cerebellum is involved in learning timing and rhythm of movements, synchronization of movements, and learning to correct motor errors. So when we're learning to walk as babies, we're getting a lot of feedback, and our cerebellum has to adjust our motor output to do the movement that we want to do. So it's unconscious. All of those unconscious relay tracts end in the cerebellum, but it's very important to what we're doing. So we'll talk about disorders of the cerebellum and how it affects you. So there are 3 broad classes of human movement. Equilibrium. It's regulated by one part of the cerebellum, the vestibulocerebellum. Gross movements of the limbs, so big, large movements, coordinated by the spinocerebellum. And fine distal voluntary movements are coordinated by the cerebrocerebellum. So the cerebellum is involved in all 3 of those classes of human movement: equilibrium, gross movements, and fine distal voluntary movements. So there's a little, this is a diagram from the book, and it shows the different areas of the cerebellum, and I don't expect you to memorize this or anything, but it's just interesting to see. It shows the input area, so it has that little purple swiggle is the vestibular system, and then the little purple area in the cerebellum is the part that corresponds to that. And then the green is the cerebrum, and the green part of the cerebellum is the part that corresponds to that. So it's just a nice visual representation of how things are going on in the cerebellum. So when things don't work, we talked about in the somatosensory system where tracts cross over and what side of the body is affected, and we'll talk about more about that in the spinal region and in the cerebrum. But when you have unilateral lesions of the cerebellum, they affect the same side of the body, so there's no crossover in that information going into the cerebellum. So cerebellar signs are ipsilateral because those cerebellar tracts stay on the same side. They don't cross the midline. Okay, easy. So ataxia, we talked about sensory ataxia in chapter 6. Ataxia is a movement disorder that is common to all lesions of the cerebellum. So this is cerebellar ataxia. It's voluntary, normal strength, jerky, and inaccurate movements that are not associated with hyperstiffness. So some of our hypokinetic basal ganglia disorders have jerky, inaccurate movements, but they're caused by that hyperstiffness because we have motor inhibition. The cerebellar ataxia are jerky and inaccurate movements. I have a couple of videos in the module demonstrating ataxic gait, and you can think of it like a wide base of support and sort of a toddling gait, because it's that uncoordinated jerky movement. So not all ataxia is caused by cerebellar lesions, so they want to be able to differentiate between cerebellar ataxia and somatosensory ataxia, because it's going to be treated differently, right? So if there's some kind of interference with the transmission of somatosensory information to the cerebellum, either by lesions of the tracts or peripheral neuropathy, that can also produce ataxia. So it can either be in the somatosensory system, it can be in the cerebellum, or it can be in the connection between the two. That makes sense, right? So sensory deficits or paravermal cerebellar lesions can cause ataxia in the lower limbs. The Romberg test, which we'll talk about, and tests of proprioception like vibration sense and ankle reflexes are tests that differentiate between cerebellar and somatosensory ataxia. So the Romberg test measures the ability to use proprioceptive information for standing balance. So it's very basic. Patient stands with his or her feet together first, with eyes open for 30 seconds, and then with eyes closed by 30 seconds. It's a pass or fail scoring. So if you fail, the criteria for failing include moving the arms to maintain your balance, opening the eyes during the eyes closed section, either starting to fall or requiring assistance to avoid falling. So if someone can stand with their eyes open for 30 seconds, they close their eyes and start to fall, then they probably have some cerebellar dysfunction. So people with cerebellar limb ataxia are unable to stand with their feet together with or without vision. They have normal vibratory sense and proprioception and ankle reflexes. So their sensory tracts are working, it's the cerebellum that's not working. People with sensory ataxia are able to stand steady with their feet together with eyes open for 30 seconds, but their balance is impaired when their eyes are closed. And the conscious proprioception and vibratory sense are impaired, and ankle reflexes are decreased or absent. So it's sort of like which end is has the lesion. So if it's the cerebellar end that has the lesion, they can't stand with their feet together, with or without vision, and they have normal sensation. And then if it's the sensation end that's affected, they have abnormal sensation, and their balance is impaired with their eyes closed. So, kind of interesting. We'll use the Romberg test for detecting some other things too, dependency on visual stimuli and that sort of thing. So this is the table from the book, Table 11.6, that basically lays out all the different types of motor control disorders. So some of them that we talked about in Chapter 10, the lower motor neuron lesions, upper motor neuron lesions, Parkinson's, Huntington's, and cerebellar lesions. So this chart is a nice chart. I like the way it's arranged, and it's a good way to tell the difference between all these different ones. And I would like you to know this information. This is a good synopsis of the information that you'll need to know for the exam.